Hello, and welcome to this RPTH Research Recap, where we want to dive a little bit deeper into the science that has recently been published in RPTH. My name is Ingrid Pabinger, and I'm a member of the RPTH editorial board. I am a hematologist based in Vienna, Austria, and my main interest is thrombosis and hemostasis. I'm very pleased to introduce Mrs. Julie Kelly and Mrs. Clara Ting. Julie is a clinical pharmacy specialist with a focus in cardiology at Brigham and Women's Hospital and serves as the current cardiology residency coordinator. Clara is also a clinical pharmacist in cardiology at Brigham and Women's Hospital and is heavily involved in precepting students and residents. Both have interests and have published on various topics in anticoagulation and cardiology pharmacotherapy. Their most recently published paper in RPTH is entitled Heparin-Induced Thrombocytopenia in End-Stage Renal Disease, Reliability of the Platelet Factor 4 heparin ELISA. We know that patients with end-stage renal disease have a high risk of thrombosis, be it venous or arterial. And they also have comorbidities, and they might develop thrombocytopenia. And it is very important to either diagnose or confirm or exclude heparin-induced thrombocytopenia because there is an impact on treatment, and therefore this work is so important. And Julie and Clara will give us a presentation on their paper, and dear Julie and Clara, we are very much looking forward now to your presentation.
Thank you so much for the introduction. We will get started. My name, again, is Julie, and I will be presenting today on our recently published paper, along with Clara Ting, co-author, on heparin-induced thrombocytopenia and end-stage renal disease, reliability of 4 T-scores in the heparin PF4. So just start off with some background. New onset thrombocytopenia can be difficult to evaluate in patients with end-stage renal disease due to multiple potential etiologies listed below. So we were finding at our institution that we were sending a lot of PF4s on patients who happen to have end-stage renal disease as a diagnosis, as a workup for HIT and heparin-induced thrombocytopenia. And we were wondering if, given the fact that there's so many other etiologies that could be contributing to the thrombocytopenia in these patients, along with their end-stage renal disease, is there, a higher chance for false positive PF4s in end-stage renal disease? There are a few small observational studies examining the diagnosis of HIT in end-stage renal disease listed here. So this first study showed that about 32.5% of patients receiving hemodialysis and receiving intracatheter heparin developed PF4 antibodies of greater than 0.4 over a 6-year period. Another study showed that there was a PF4 positivity rate of over 2 years in patients receiving maintenance hemodialysis with heparin or low molecular weight heparin. So both studies showed that, there is this potentially higher incidence of positive PF4 rates in these patients. So anecdotally, as I mentioned, our institution has observed an increased incidence of positive PF4 but negative SRA values, specifically in patients with end-stage renal disease. And as mentioned above, there really is only some small studies out there looking at the specific patient population, and there are a lot of unknowns. So we decided to do a retrospective review of patients at our institution who happen to have end-stage renal disease. And the purpose of this study, or objective, is to correlate 4 T-scores, heparin, IgG heparin platelet factor 4, PF4 heparin ELISA results, and serotonin release assays in patients with end-stage renal disease to evaluate whether end-stage renal disease can increase the likelihood of a false positive HIT diagnosis. And this was important, we thought, because when patients are diagnosed with HIT, they oftentimes have to go on direct thrombin inhibitors, other alternative anticoagulation treatments for periods of time, and it can potentially increase their hospital length of stay and potentially lead to other worse outcomes. So we want to overall, decrease the rate of falsely identifying patients with HIT to avoid these potential outcomes. So to get into the methods of our study, this is a single center retrospective review at Brigham and Women's Hospital. We included adults admitted to Brigham and Women's, or BWH, with a PF4-heparin antibody test between October 2015 and September 2019. We excluded patients who did not have end-stage renal disease, and our definition was creatinine clearance less than 15 milliliters per minute or receiving renal replacement therapy, including continuous veno-venous hemofiltration, or CVVH, hemodialysis, or HD, and peritoneal dialysis, PD. For our study, we used a 4T assessment score to test pretest probability of HIT as documented in the medical record or confirmed by the study team via retrospective chart review. So I have the 4T scoring tool listed here for your reference. This is our institutional 4T scoring tool, as well as it aligns with published 4T scoring tools that are well validated and commonly referenced. So basically there are four major categories of the 4T score: thrombocytopenia, timing, thrombosis, and other potential causes. And so you use those specific scoring tools to assign points in each of those four categories. And then you get your total score that correlates with the probability of HIT based on the 4T score. So a low score is 0 to 3 points, meaning less than 5% probability of HIT. A moderate score is 4 to 5 points, meaning about a 14% probability of HIT. And a high 4T score would be 6 to 8 points. And that would correlate with about a 64% chance probability of HIT based on previous data. So to get into some more endpoints and definitions, at our institution, we utilize an IgG heparin platelet factor 4 ELISA assay, and our cutoff for a positive PF4 is an optical density, or OD, of greater than 0.4, greater than or equal to 0.4. A true positive PF4, as defined by our study, is a patient who had an intermediate to high 4T score, as well as a optical density of greater than or equal to 0.4, and with documentation of clinical diagnosis of HIT. A false positive PF4 would be defined as a PF4 that was positive, but with a negative SRA score, with a negative SRA value and a 4T score of less than 4, which would make the pretest probability low, and a clinical decision to not treat for HIT by the covering team, as documented in the chart. And indeterminate cases, such as low to intermediate 4T score with a negative SRA, were classified based on clinical assessment and treatment per clinical team. And now Clara will continue on to talk about our results.
Great, thank you for getting us started, Julie. So here are our baseline characteristics. So our median age was 65 and about 63% of the patients were male. As far as the ESRD subtype, so patients were most commonly on hemodialysis at 55%, followed by CVVH, 35%, with about less than 10% of patients having a reduced creatinine clearance without any renal replacement therapy. Using heparin products was indicated for many indications, including therapeutic, prophylactic, and intraoperative use. And the most common heparin product that our patients were exposed to was unfractionated heparin at over 80%. It is important to note that our inpatients did have potential other causes of thrombocytopenia, with a good amount of our patients having sepsis, being maintained on ECMO, or undergoing cardiac surgery with cardiopulmonary bypass, all of which can contribute to thrombocytopenia. So these are the patients that we worked up. So after evaluating all patients in our hospital who had a PF4 result between that time frame, we found that 254 of those patients met our inclusion criteria for ESRD. And of those patients, we had 29 patients who had a positive PF4 assay result. So this is a positivity rate of about 11%. So of the 29 patients, 10 patients had a positive SRA result, and these patients went on to be treated for clinical HIT. Surprisingly, 18 of the 29 patients with a positive PF4 results actually had a negative SRA confirmatory result. And so in these patients, we went on to consider their 4T probability score. So 10 of these patients were classified as indeterminate cases with a intermediate to high 4T score. And of these, 3 were treated as HIT despite the negative SRA, whereas 7 of them were not treated for clinical HIT as decided by the treating team. The remaining 8 patients who had a positive PF4 but a negative SRA and low probability 4T score, these were determined as not having HIT and were not treated for it by the covering team. And so these are the patients that we classified as false positive PF4 results. Pictured on this slide are our patients' 4T scores and the components broken down. So overall, the median 4T score for our PF4 positive patients was 5, and for PF4 negative patients was 3. And of note, the median points for thrombocytopenia in both groups were 2, meaning that a lot of these patients did have platelet decrease of greater than 50%. However, the thrombosis median points were 0, both for PF4 positive and negative groups. So it is interesting because we do know that HIT does commonly present with thrombosis, but this was not quite the case in our study. Moving on to the lab results. So in the first table, we have the PF4 optical densities broken down into the SRA positive and negative groups. So we can see that patients who had negative SRAs mostly had lower PF4 optical densities, less than 1.0, whereas those who had positive SRA results, they tended to have optical density than 1. Then to break down the results by 4T score, we see that patients in the positive SRA group, they mostly had intermediate to high suspicion in their pretest probability score. So about 90% had at least intermediate to high suspicion. And this percentage is a lot less in the SRA negative group. Only about half had intermediate to high suspicion based on the 4T scoring. And then looking specifically at cases where the PF4 was positive, but the SRA was negative, 8 patients had a low 4T score and were not treated for HIT. And these patients generally had lower PF4 optical densities less than 1.0. So we've overall found a PF4 false positivity rate of about 27% in our patients with ESRD. And so these patients had negative functional assays and were not treated for HIT based on clinical assessment. Our study found that patients with negative SRAs, they were more likely to have lower optical densities of 1 and 1.5. So it may be that we may need to consider patients meeting the PF4 criteria, the PF4 result with a higher cutoff in this population specifically, or have some sort of different pretest probability scoring. Compared to prior studies of ESRD patients on maintenance hemodialysis, our study does provide some novel data on inpatients who have maintenance hemodialysis as well as CVVH, including those with critical illness or post-surgery. And our study limitations do include our retrospective design and a smaller sample size. So in conclusion, our study found that 4T scoring and PF4 results did not quite consistently correlate with a clinical diagnosis of HIT in patients with ESRD. So further investigation is warranted to look into the optimal strategy of diagnosing HIT in the ESRD population.
Thank you, Julie and Clara, for this very nice presentation. And as I already said, it's a very important topic, yeah, and it seems to be very hard to make the diagnosis of HIT or exclude heparin-induced thrombocytopenia in patients with end-stage renal disease. Looking at your patient population, please correct me, it seems it might be a mixture of those who have had end-stage renal disease and had some intervention, but also that developed end-stage renal disease after sepsis, after intervention. Is that correct? So that's a mixed cohort and population?
Yes.
Yeah. When you have patients with end-stage renal disease who are on hemodialysis, they have very frequent heparin administration, 2 times per week, 3 times per week. And one important aspect of the 4T score is the timing. How did you deal with that in your study, and what would you advise to doctors that are on treating hemodialysis patients?
Yeah, no, that is a great question. You're absolutely correct. We had a mix of patients chronically on hemodialysis and patients who, had an acute renal injury and were then placed initially on renal replacement therapy during their admission. To answer the first part of your question, as far as how we dealt with deciphering the timing of heparin for our 4T scorings when we didn't have a documented 4T score on the chart, and us as a study team had to retrospectively determine the 4T score. Fortunately, we are in a health system, so a lot of times these patients had outpatient hemodialysis visits within our health system. And there was documentation of what kind of flushes and medications they were receiving during their dialysis sessions. So oftentimes we could determine the previous timing to some extent of our patients getting chronic hemodialysis. However, that was definitely a limitation of our study, that we couldn't always determine the exact timing of the previous heparin, and oftentimes if we couldn't determine the timing, these patients may have been excluded. And then to talk about, how can this study help providers who are dealing with these patients on hemodialysis? It is definitely a challenge. I mean, there is no clear-cut answer, but just knowing that your patients are potentially more susceptible to thrombocytopenia and thrombosis. So just really using our pretest probability that has been validated and really making a decision if we should be sending a PF4 for further workup, or should we be attributing this thrombocytopenia to their dialysis sessions, because there is a lot of downsides to sending a PF4, it coming back positive, having to wait for an SRA to come back if there is even SRA capabilities, and then that you're left with a patient with a positive PF4, and it's unclear of whether we should be treating this as HIT, given that there were so many other concerns for other reasons for thrombocytopenia.
So it's great that at your hospital you had the serotonin release assay. And we talked about that assay a lot during the problems with vaccination, with COVID-19 vaccination. Who has the serotonin release assay? And not many hospitals have that available. So some hospitals would really have to go along just with a 4T score, some clinical impression, and then PF4 ELISA, that's more widely available, I suppose, also in the US and Canada, as it is in Europe. So would you think that a cutoff of the PF4 could help also to have some hint whether indeed it's hit or not hit?
Yeah, I think so. I think our institution uses a lower cutoff of 0.4 with the reasoning that we don't really want to miss anyone who could potentially have hit. But there is a lot of prior evidence, and our study does kind of reinforce that higher PF4 optical densities really should be considered. Most patients who do have a clinical diagnosis of HIT will present with a PF4 greater than 1 or greater than 2.0. So that is something to consider in patients who may not have the SRA readily available. Our institution, we do not have the SRA in-house, but we do have the capability for send-out testing, which can take about 5 business days. So we are also in a tough spot when we are waiting for the results of the SRA in patients who might have a intermediate optical density. So we tend to kind of treat according to our pretest probability. If we at least have an intermediate to high suspicion, then these patients should be started on treatment with usually a IV direct thrombin inhibitor while we await the results of the confirmatory test.
Mm-hmm. Yeah. So the incidence of thrombosis is high in end-stage renal disease patients. We know that from large studies, but it was not high in your specific cohorts that were positive with PF4. On the other hand, in your study, but also other studies showed that PF4 ELISA is more often positive than in the general population. Do you think that let's say silent hit or something like that contributes to thrombosis in dialysis patients or in end-stage renal disease patients?
I mean, certainly, potentially. I think that our study wouldn't really show that, given the fact that we had, like as you mentioned, a lower incidence of thrombosis as compared to even the general, what data we have for prevalence of thrombosis in end-stage renal disease in hospitalized patients in general. But I think that if anything, our data might say that that is not the case, given the fact that these patients had positive PF4s and they still had a lower rate of thrombosis. Obviously, a small sample size, we can't make any conclusions on that matter from our study. It would be interesting, with larger, more controlled studies to look at that specifically, but I don't think our data supports that there is an increased incidence of silent hit in end-stage renal disease.
And we should not just perform PF4 ELISA when we want to have a risk of thrombosis in dialysis patients. No.
Exactly.
Do you agree?
Yeah.
Not as a screening.
So
Just when
low incidence of thrombosis is kind of
okay.
Not sending unnecessary PF4s when the pretest probability is low.
Yeah. So what would you suggest as next most necessary steps or studies or investigations in the area of end-stage renal disease and heparin-induced thrombocytopenia?
Yeah, I think that it would be great to have a controlled study where we compare patients with end-stage renal disease and those who do not have end-stage renal disease, and compare 4 T-scores and optical densities of PF4s as they correlate, and SRAs when available, as they correlate to a clinical diagnosis of hit and incidence of thrombosis. So I think that that would be very helpful, because as of now, we just have small observational data in both end-stage renal disease and non-end-stage renal disease populations. So that would be a great next step as far as making any sort of conclusions on this topic.
Yeah, thank you, Julie and Clara, for presenting your interesting work and for giving us more insight into this topic. And we know it's not easy and work is ongoing, and we have to work on that to improve the diagnosis. So we hope that the viewers will read the full paper, and we hope that you will publish again in RPTH, of course, and everyone listening, of course, and also in JTH. And thank you for watching, and please keep an eye out for the next RPTA recap. Thank you.
Thank you very much.